And now we move to the live case in the box and from the Nhân dân Gia Định Hospital.
Good morning. Welcome to Gia Đình Cath Lab. Thank you so much for the opportunity to share with you this PCI case, how to deal with severe calcified lesion. We're here in our room with the fellow Dr. Kane. We have Dr. Tiến, the assistant operator. The staff help us today, Subnet technician Tú and Long. We also have the IBI team, Dr. Hóa and Dr. Minh, who are in charge of the analyze the OCT and IVERS interpretation. And now, Dr. Quang, let's introduce our case with you today.
So we have a 71-year-old male patient admitted to our hospital with exertional chest pain. His history including hypertension and heavy smoking. He has CaseC6 chest pain despite nearly 3 months of OMT. His lab test was non-significant, including the Meran-2 pre-procedure score of 0 and a high clinical risk profile with the precise DBT score of 35. His echocardiology is quite good, and on the EKG you can see non-significant findings despite some PVCs. On CAG, his RSA has a 50% lesion at the middle. On the left side, you can see there is a heavy calcified lesion from the ostium to the body left main. Also, there is an ambitious left main bifurcation lesion. On the LD, you can see a diffuse and heavy calcified lesion from the proximal to distal LD. And there is another true bifurcation lesion of LD and principal diagonal. To summarize, we have a 71-year-old male patient admitted with chest pain. He has triple vessel disease, heavy calcified lesions, and bifurcation lesions. So at this point, we want to know your opinion about how to overcome this challenging PCI case. Thank you.
We can see here, maybe you put the slide, the summary of the case for the slide so people can see it. So we would like to have a option and comment from the panelists about how we did with this case. So maybe Dr. Huy first.
Yes, thank you. So I think this is a tough case, complex, because we can see the two continuous bifurcations between left main LED left circumflex and also a big diagonal bifurcations LED diagonal. So I think any of branches that is important, and our PCI plan should be planned for preserve all of the three vessel, the left main LED, the diagonal, and left circumflex. So I think concerning the complexity of anatomy, then all of us, I think, will be agree that imaging will have more information. So my center, we don't have OCT, so IVERS will be my choice. And yes, a big guy. And then I think I will wire 3 branches, LED, diagonal, left circumflex, and then try to figure out how extents of the 2 bifurcations lesions with IVERS imaging is how is a plug at left main distal left main LED before applying any procedure for these patients.
So you prefer like imaging first and then decided, right? So from the very beginning, you think about the balloon or stent, or we decided later?
Yes, decide later after my the imaging. Yes.
Okay. So I would like to hear the comment from Dr. Hendrik, please.
Yeah, first impression is run away, but no, I can certainly. Don't want to add too much image-guided PCI of the LED first. I might split it into 2 sessions and two procedures. I missed the LV function. Is the LV function preserved? Yeah. Yes. Yeah. So image-guided PCI after LED, likely with atherectomy and osteal circ. I wouldn't stand this, but finish with a DCB if I have a possible debunking result.
So the question here is you think about you prepare backup for the cert PCI, or you just ignore the cert?
No, would go for the circ as well.
So we would like to hear the comment from Professor Alec.
Hi, yes. So first of all, I would be interested in the RCA to see what's going on there, to anticipate potential issues if there's also compromise on the right side. My main concern looking at that, if you're planning to go for the LED and left mainstem very calcified, what is our plan for the circumflex? So it's not only we're talking about left main calcified LED, but potentially also bifurcation issues at the LCX. So I can't see it very clearly here, but one of my priorities would be to evaluate the circumflex to see what's going on at the ostium there. Of course, in addition to doing imaging on the LED on left main.
So in this case, you do the state PCI, or you try to prepare for every PCI procedure?
I guess once you start working on the left main, you're kind of committed to do something there. So I think we have to figure out what's going on at the circ ostium there, whether it needs treatment as well.
I sort of presume that the right is going to be large, isn't it? Because the circumflex is fairly small. So I would just probably protect with the wire and then decide whether there's anything that needs to be done after the stenting or the until left main. The only thing is, question is how do you want to make it easy? Because if you want to end towards the end, and there is a bifurcation diagonal and also the circ, then you may be dealing with 2 lesions and 2 bifurcation, and sometimes that can be difficult, and therefore you need to really think about how you're going to do this.
Yeah. So Rosalie, in this situation, you do think with thinking about the FFR, or you base on everything on the iBurst?
Well, I think looking at it, it's significant lesion for both the diagonal, if that's probably diagonal 2. Though from the what do you call that, the spider view, it doesn't look that bad. But the LED looks significant, so I will probably base the treatment strategy on just the imaging.
So is there any comment from the floor? So I think that through the panelists, I think that the people want to see how the imaging is the LAD and diagonal, and especially the left main and the third ostium, and see what was going on, and then we decided later.
We can see on IVUS, mid-LD have a long and severe 360-degree calcium, which is very hard to modify by just balloon angioplasty or even cutting scoring balloon, but this is a perfect target for intravascular lithotripsy. In proximal LD and left main, we can see a large calcium sheet which extends from superficial that we can see on IVUS to deep layer we suspect on angio. Distribution predominantly in one side of the vessel wall and the lumen area is not so bad. The pattern of calcium might be more challenging to modify with device. Especially, the lesion of the left main ostium presents 2 large calcium sheets on the opposite side. It's about 150 degrees and is still a fibrotic tissue between 2 calcium. Reference lumen diameter of LD is about 3.0 and left main is about 4.0. Length of the heavy calcified part is around 18 in the mid LD and 17 in proximal LD to left main. Lumen area of osteo left main is 4.06 mm², which is indication for intervention.
On OCT, we identified a low backscattering, low attenuated lesion with a clear border on the vessel wall, suggesting calcium.
This calcified lesion extends from the second large septal branch at the mid-LD to the ostium of the left main with 58 mm total in length. The MRI site is near the first septal branch with an area of 1.06. On the cross-sectional image at the mid-LD, the lesion is heavily calcified with the circumference of 360 degrees, thickness more than 0.5 mm, and the length of this lesion is 16.6 mm. At the proximal LD, we identify a thick calcified lesion covering 180 degrees, extending from the site between the second and first diagonal branches to the ostium of the left main artery. Its length is 19.7 mm. Regarding measurements, the EAL of the distal reference diameter measured at the second large septal branch, which is the number 1 marker, is 3.0. We cannot measure the vessel diameter of the proximal LD due to the very thick layer of calcium. The largest mean lumen diameter of the proximal LD between the first and second diagonal, which is the number 2 marker, is 3.03 mm. We cannot measure the vessel diameter of the ostial left main and LD either. The ostium of LD, which is the number 3 marker, has a thick eccentric calcified lesion with a lumen area of 3.83 mm square. At the left main, we identify a superficial and very thick calcified lesion causing tight stenosis with an MLA of 4.78 mm square. Moreover, OCT can help predict the risk of side branch occlusion after main vessel standing. Any side branch with a branching point carinative plane less than 1.7 mm and carinative angle less than 50 degrees is prone to the side branch complications. Based on these characteristics, we identify that the second diagonal branch has a high risk of occlusion. After OCT and IVUS examination, we have the diagnosis of this lesion, which is heavily calcified from ostial left main to the mid-LD with double bifurcations of left main LD L6 and left main diagonal. We have 2 questions for everybody. What is the best intravascular imaging for guiding PCI at this type of lesion? And what is the intervention strategy for this patient? Thank you.
The imaging, right? You don't touching the, okay. So we started again with the Dr. P.
Yeah, definitely. I think the left main looks terrible. Yeah. So I think IVUS can be useful tools here to decide to guide our procedure. So because of heavy calcified, so definitely I will need some balloon, some not the plain balloon, just NC balloon. But I think it depends on which devices I have in the cath labs. So I think either cutting balloon or scoring balloons will work because now we have more flexible balloons to coming down. Yeah. Otherwise, I think IVL can be a good choice for these situations. And then we balloon IVL from the whole LED to left main. Then we see after that imaging again before stenting.
Yeah. Regarding the first question, I'm very comfortable with IVUS, but both tools work, OCT or IVUS for sure. Giving the very large amount of calcium distributed from the left main to the mid or distal LED, I think IVL would be a good tool, but you need several balloon sizes. Same as RODA, not one burr size would work here. So if I could choose from all the tools, I would go with orbital, low speed in the mid to proximal LED, and then high speed in the ostial and left main.
So you to more clarify that in this situation, because you think that patient might need to have many IVL, so that's why you choose the orbital, right?
Yeah, I think I'm not a heavy IVL user. I have to confess that, but I believe I would need different balloon sizes to cover mid to proximal LED and left main. And wire bias is an issue in atherectomy, and I think rotor would be difficult to ablate in a certain amount of, on a good portion.
Yeah, thank you. So, Professor Alex.
Okay, so the two questions, I'll try to be fast because it's going to be redundant a bit here. Imaging, whatever you are familiar with, I would prefer IVAS. It's probably going to be a long procedure. If you go OCT, you have to clear the contrast all the time, multiple injections. I would not prefer here. I would do IVAS, number one. With that amount of calcium, I think IVL would be ideal. Again, you can probably get away with one size, maybe a 3O. I mean, the main thing is that you have good contact with the vessel wall and the lesions are so tight, maybe you get away with one IVL. Yeah, if you cannot cross, of course, you have to ablate first, what ablate. So,
yeah, on our side, I think we can see that OCT gives beautiful images, especially with calcium, isn't it? But I'm more used to IVAS, so I tend to use more IVAS than OCT. Now that we have got injectors, so I'm trying to use more, OCT because the images are now going to be quite good because it depends so much on how you inject and the lesion proximal to it. On our side, this is a case that we will probably use lithics mechanical IVL. The shockwave IVL, as I agree with Hendrik, you got to use multiple and it's going to be more costly. It's only going to be limited to 80 to 120 pulses depending. So on our side, we tend to pre-dilate first just to get the vessel to open up a bit. And then once then we will then be able to use lithics and multiple lesions, and most times it works.
So Rosalie, you mean that you use a non-compliant balloon first and open first and see, and after that you choose the side of the lithotripsy, right?
Yeah, again, we try not to go very high pressures because we try not, we don't want to crack the calcium because it's very unpredictable, with a balloon. The size, of course, depends on the imaging, and we tend to use 1:1. If it's tapered vessel, then we may want to choose this vessel size, the balloon to vessel artery ratio, which is for the distal. And as you go more proximal, then we go high pressure because it's a semi-compliant balloon. At about 20 atmospheres, it will be at least half the size of the previous balloons.
Yeah, so I would like to ask our panelist, Dr. Takashi. You already present a very nice. So in this situation, what kind of the imaging you choose and how to do with the PCI?
Okay, thank you. So in this case, left main is a problem. So if you want to see the ostium left main, I think IVAS is better. I don't think that you show that OCT image, the left main ostium. Is that really left main ostium? I don't think so because the OCT, it's difficult to see that real ostium. So if you want to see ostium using OCT, we need guide extension catheter like telescope or guide liner. Both only two. The other guide extension cannot see the outside guiding. So if you want to see ostium using OCT, a special guiding catheter guiding extension is needed. Then, so for this region, I think IVAS is easier to check from the distal LD to the ostium LD. Then for this region, for me, the rotor first. Then it depends on the guide wire bias, but I just do a rotor first, then check the IVAS again, and then try to do the next step. Actually, in Japan, we have two bar or two devices like a rotor IVL or rotor OS or two rotor. So we just do a first rotor, then check IVAS again. That's our strategy.
Yeah, so you see the home people here maybe prefer the IVAS because you can see the whole thing from LED to the ostium. And the second one is a lot of different opinion. But I can see here like IVL is the first option and second option is rota first and then see what was going on. Because in this situation, you might need end up with a lot of IVL and then the cost increase. So now we ask again and see how the people from the Nhân Dân Định hospital to do.
In this case, successful crossing was achieved with both the IVUS and OCT catheters. The subsequent imaging confirms by the presence of severe calcium in LAD. So what the device should be used for this case? Based on the combined IVUS and OCT results, we think that the intravascular lithotripsy is favored for this situation due to the concentric calcium arcs, thickness, depth, and length of calcium, and especially the involvement of the left main ostium calcification. Based on the severe calcium assessment, we temporarily divided the LAD into two segments. The first segment related from the big diagonal 2 to mid LAD, presents by the heavily calcified concentric calcium arcs spanning from the 270 to 360 degrees. The procedure will proceed directly with an IVL balloon, but the second segment from diagonal 1 to ostium left main, having the eccentric superficial and or deep calcified lesion. Besides the IVL we can choose all the balloon-based surgery, then IVL such as the gusting balloon or scoring balloon. But the ostium left main calcified lesion, or we can see on IVUS only, it can be treated by IVL or orbital atherectomy. Therefore, IVL is still the right choice for this the second segment. IVL balloon size what determines based on the IVUS measurement. We can go with a single balloon 3 out of 15 from mid to proximal to mid LAD. The balloons will just utilize this balloon. I think we will utilize for the body and ostium left main calcification. But if the IVUS image the post IVL is optimal results, so at the time the the IVL balloon 4 mm IVL balloon will subsequently be employed. OCT also help us to predict the high risk of the side plate occlusion for diagonal 2. Therefore, protection of diagonal 2 is required when stenting this the bifurcation. So what is the best IVI guide PCI for this case? OCT is superior for visualizing calcium distribution and predict the side plate occlusion. However, IVUS is preferred for visualizing the lesion at the ostium left main. So, if I can, I choose both.
I'm ready. 2, 4, and 6. Okay. We will stop. What? Stop. Stop. Hey, no. Okay. 10 seconds.
Its IVL balloon 3 mm was unable to cross the LAD, so we have to predilate LAD with the 2.5, 15 and C balloon first. Secondly, the IVL sonic cracker, the 3 out of 15 is deployed in 4 positions from the mid LD to mid to proximal LD as well in the body and left main ostium. It's delivered the 1 to 2 seconds at each position. IVUS assessment is conducted following IVL to evaluate the success of calcium modification.
After using the 3.0 mm IVL balloon, we can see that the LD lesion had been significantly modified. There is evidence of dissection of triticide, along with multiple calcium plaques observed in the 360-degree calcified segment. In contrast, the left main and proximal LD lesion remain unchanged because it's mainly characterized by unilateral calcium and a balloon size that appears too small than the vessel diameter. And we can see that the ostial portion of the lesion is still severely narrow, and the calcium plate had not yet been adequately fractured. Left main osteo show two large calcium plates with approximately 200 degrees of calcium arc, but margin is still fibrotic. The calcification is extending from superficial layer on IVUS to deep layer, which can be visible on angiography. So, how would you treat this osteo lesion?
So a little bit how to treat the ostium of left main, Dr. He first.
Yes, I think it seems that the IVL balloons doesn't crack the calci as ostium of lemon, and yeah, we may need a bigger balloon. So I think I will try with maybe a 4NC balloon first to see, or 4 cutting balloon to see it can work or not, because a second IVL can be so expensive. I don't know.
Dr. Hendricks.
Yeah, bigger balloon, reassess the MLA. If it's big enough, you can stand. If not, you need more ablation. Yeah. Or a different technique, I mean. Yeah.
And one more thing I noticed is maybe some contrast staying at ostium left main. Is it from the beginning? Is there some dissections there at the left main at this moment?
I think the heavy calcium that throws a bit of a shadow, actually. Yeah, so I mean, in practical terms, normally I rely on the balloon expansion in calcified lesions. If the IVL can expand well, I'm usually happy, and I don't even look with IVAs for cracks in the calcium. Sometimes we just go ahead and stent and assume the vessel is sufficiently prepared. Here there are no cracks at all, and we know the 3O is too small relatively for the osteo left main, so it needs more preparation to save cost. I agree, I probably would go with a normal balloon first, normal cutting or scoring balloon first, 3.5, 4.0 or whatever, and see where that is doing the trick.
Yeah, I think, well, I couldn't catch the size, I mean, of the left main. I thought it was going to be more than 4, I think. Yes, so sometimes if it's more than 4, if we would want to do another IVL, the biggest is only 4, it might not hold very well. So I would go for a non-compliant bigger balloon, at least, and 4.0 or 4.5 to see whether it cracks open.
So how about Dr. Takashi?
I think the same. Yeah, I use a bigger balloon, but maybe try a scoring cutting balloon, a bigger one, then to see how it works.
Yeah. So in this situation, do you protect the cert? Because I didn't see the people.
Just for protection, the guide wire protection. I think that's enough.
Yeah. Okay, so I think here the people think that the ostium of the left main is too big for the second IVL and maybe too costly. So we might choose a normal and bigger balloon for 4.0 or 4.5 non-compliant balloon or cutting balloon and see what was going on for the left main. And after that, we finish the case. So back to the Netherlandic team.
I'm ready.
Second idea.
4 and 6. Okay. No, stop. What? Stop. Stop. Hey, no. Okay.
Address the calcium in body and ostium left main segment. We use the 4.0 to 15 LVL balloon using the 2 cycles with different balloon position, as you see on the CaseC, to ensure the adequate modification of the read ostium left main calcium and before stenting. IVL to balloon 4.0 look well expanded in CaseC is predict the successful of cracking calcium.
After perform IVL balloon dilation of the left main lesion, a dissection can be seen starting at the bifurcation and appear to extend up to the left main ostium. This is very large dissection and seems to have flipped up and disrupt the calcified plaque at the ostial segment. Following IVL balloon dilation, the vessel diameter improved from 4.0 mm square to 5.65 mm square.
We use the professional stenting strategy for both bifurcation lesion. The first we deployed the 1DS, the 3042 in mid-LAD. In diagonal LAD bifurcation, check balloon technique with the 3015 is employed to protect the diagonal 2 branch. The second DS, the 3.5 to 38, is employed from ostium left main to mid-LAD and overlap the first stand. We use the short NC balloon, the 408, 22 mm straight in the left main. The final step is to perform both dilatation NC balloon, the 3.515 from 18 to 24 atmosphere in the proximal to mid-LD to ensure full expansion throughout the stand segment. You can see balloon is not expand well, but acceptable. Most heavy calcification location in mid-LAD.
The final result after stent implantation, no evidence of dissection were observed in the distal stent segment. The LD lumen area showed marked improvement, reaching about 8.0 mm square overall. Minimal stent area at the site of prior 360-degree calcification achieved about 6.0 mm square, and the lumen area at the LD ostium measured about 7.24 mm square. Body left main is about 12 mm square, and left main ostium is about 10 mm square.
And now this is the final isographic image. We have achieved the widely patent lumen in left main and LED in the IVERS image with the Dimitri float. The result is okay except the section is ostium in left main. We left it alone and we continue the optimal medical treatment. We will really get this case 6 months later. How to deal with the severe calcified coronary lesion? At first, we have to accurately quantify the calcium severity, so IVI is an application. The second is that how to prevent the stent underexpansion in the severe calcified lesion, so that we have to prepare the lesion for the optimal blood modification. And the last, how to deal with the thick, deep, and ostium calcified lesion. IVL is the ideal device, as the case is demonstrated.
We have just finished our case today. So thank you for your attention and hope to see you on the next conference on 2026.
Thank you, the Nyanzadik team, for the great case. However, we need more comment and suggestion from the panelists. Should we stop with the dissection of the left main like that? Dr. Hui first.
Yeah, I think it looks a bit scary on angel, but anyway, for me, I will wait for maybe 10 minutes more in the cath labs, leave patients there, and then recheck by another shot after 10 minutes. If the flow is good, then we don't see any hemodynamic change, then I think we can stop the procedure.
Yeah, Dr. Hendrik.
The question was regarding left main dissection. I wouldn't leave that alone.
I think lately we are developing a lot of tolerance to major dissection, even in large vessels and proximal vessels, mainly driven by DCB usage. And all the DCB enthusiasts probably would leave it away, and they probably would have even placed possibly a DCB in the left main just to optimize that further. In any case, I would make sure that patients are on very strong dual antiplatelet, ticagrelor, aspirin, and I probably would give maybe a couple of days of anticoagulant as well, just to prevent acute thrombosis.
Well, I agree. And yes, I would switch over to prasugrel or ticagrelor just to be on the safe side, but I would not do anything. I would even probably not delay discharging. I would probably discharge the following day.
So actually, in this case, you put the 3.5 stent from the LAD to the left main, or just at the ostium of the LAD?
We developed two stents, one 3 hours on the proximal to mid LAD and one 3.5 overlap stent from the ostium left main to LAD, and both dilatation pop at the left main at the 4 or 22 atmosphere, because the MLA we see the diameter of the left main is the more than the 4.2 millimeter. To be honest, after the stent, after stenting, and also we see that the section type P on the left main, we also worry a lot. But actually, the patient is stable. The hemodynamic stable, has no chest pain. We also watch the patient on the table not only 10 minutes, but also nearly the 30 minutes. Yeah, that's it. But actually, he has no chest pain. The only thing is that, but actually that if you ask me to do more, I have nothing how to do next. Yeah, just watch. And I think I totally agree with Dr. Henrik that I will leave it alone. Thanks for that. The patient is still stable, and to chapter 3 days later. Once again, thank you, the Chairman.
I still got one more question for you.
Yes.
So if you look back the home procedure again, if you start again, should we do the IVL for the left main, or we just do for the LAD and leave the left main there without touching the left main?
Actually, I really want you to touch the left main, because you see that also the heavy calcified on the left main also. But actually, if I have the chance to do this case again, I don't use the 4O, the IVL balloon, because actually you see that we all know that also micro calcification crack. If we use we didn't see the macro, but actually also have the micro calcification crack. The second is that when we see on the balloon or the 3O, we see that it's well expanded. And if I have the chance, I will use cutting balloon or NC balloon more. That's this. And I think that, or even at the time I deployed the stent already, I not need to use the ball balloon, because it makes it more expensive, and also it's make it more disadvantage like this. That's it.
Yeah, thank you. And
you wait, not just the certain that if the uplift the closure of that man, it will cause a sudden death, not chest pain. And I do agree with you that the most important, we should use antiplatelet strong to prevent the thrombus. If thrombus occur, the patient have sudden death.
yeah, Dr. Takashi, do you have any comment or suggestion after you see the whole case?
Okay, I have a question for you guys. In Japan, some people say that we need a volume reduction for calcified regions. So, okay, so for the goal of the calcified region treatment is we get a good MSA, the circular, stent expansion maybe. But some of the Japanese people think we need a volume reduction. So shockwave doesn't, reduce volume. So rotor or OS, maybe the bigger rotor, they, sometimes say you don't do volume reduction. You should. So how do you think the idea of a volume reduction?
Well, of course, it will be ideal to actually try to reduce volume, but data has been shown to be good. What you need to do is you need to have a good span expansion. That has been quite consistent. And it's a bit more practical that way, because not many people actually use all the atherectomy device. And I think what I would say is that as long as you prepare the vessel very well, and then if you have to put in stent, ensure that the stents are quite good, and of course there's no stent edge dissection, and I think that's fine. I think I would accept that. In this case, the dissection actually was within the stent, right, at the stented side, right? So I believe that's still all right, because the propagation will not be there, because the stent struts is actually over the dissection part, and I think that should be all right.
Yeah. So I think that actually now we have a limitation using the allotted device. So that's why I accept that we can based on the expansion of the stand is enough. But maybe in the future when the cost is reduced, and then we try to follow the Japanese colleagues, try to reduce the volume of the calcification.